Good morning, guys. I think we can start. So I'm sorry that I assume that my presentation, which I was working with last week, is in this machine. I think I'd come with a stick last time, but I managed to get another presentation to contain the same subject in the computer I'm using today. We were sort of going through the fetal heart, was we emphasized I think it should be 2 weeks ago, but fetal cardiac defects are the commonest defects globally. So therefore, it means anyone who scans fetuses should be well versed with screening of common fetal heart abnormalities. It is important that we all understand, or we all get the competency of examining the fetal heart. Before you is a 4-chamber view. The question is, how do we arrive at the 4-chamber view? Anyone who knows how to do an abdominal circumference properly should be able to arrive at the 4-chamber view by just doing a superior sweep or sweeping up the baby in a straight line. If you make a straight sweep from the fetal abdominal circumference plane, you will meet a plane where you will see the heart. And in this plane, how do you know you're in the correct plane? You should always see one rib. When in this plane, you can see a rib there, then another rib here. You shouldn't see multiple ribs that you are cutting through. If you do that, you'll be in an oblique plane. And you cannot examine the heart if you are not in the correct plane. The tricky part of the heart is that if we are oblique, most if you are oblique going to the abdomen, you may see the heart and the heart and the stomach in the same plane, and you may think probably you have a diaphragmatic hernia when you have none. And besides, the ventricles will not look symmetrical, and you may falsely diagnose asymmetrical ventricles when they are not. So getting the right plane when you are examining the baby's heart is very crucial. Even for those who are scanning today, try to make this sweep. When you get a perfect abdominal circumference, try to just make a sweep going up the baby. You are going to encounter the 4-chamber view. That is how simple it is to obtain it. After obtaining the 4-chamber view, you now need to be systematic in your examination of the 4-chamber view. Why should you be systematic? If you are not systematic, you may miss some subtle issues on the 4-chamber view. It is reported in the literature that 80% of the cardiac defects can be identified by a proper examination of the 4-chamber view. So the 4-chamber view has to be examined properly. If you are to pick 80% of the defects. when you are looking at the heart, we prefer that you examine the heart as it moves. So let's get the heart to move now. So this is how you should be looking at the heart, or this is how you'll be looking at the heart when the baby is in uterus. You look at the heart when it is in motion, so that you don't only check the structure, these structures, but you also get the chance to see if the valves are indeed opening. We can slow down these movements and demonstrate the opening, unless if our frame rate was low. Because if your frame rate is low, you are not able to capture the opening and the closing of the valves. You have to have a high frame rate, right? So we can see here, oops, let's see. You can see valves opening. It's more marked on the right there, in the left ventricle, the mitral valves, valve opening, and then the valves closing. If you check most of your the machines we are using, there's something called cardiac setting or fetal heart on the setting. The reason why you have to use that app of cardiac setting, of cardiac examination, is so that you can accommodate the high frame rate, because those settings were already done to accommodate the fast beating of the heart. So that if you do scan the heart using the OBS 2 and 3 settings, you may not be able to capture the opening and the closing of the heart valves. Why? Because the frame rate in those settings is on the lower side to be able to capture the fast movement of the heart. So there is a reason why the cardiac settings are in the machines. It's so that you can examine the heart properly and capture the high frame rate that the heart examination requires. So please understand this. This is part of knobology and also the physics of ultrasound. So when you are examining the heart, you change the settings on the machine to cardiac settings. Those who have scanned with us, I think you've seen us always changing when you are now looking at the heart. We go to cardiac settings so that we can capture the fast movements of the heart. Then how should you be systematic with your examination? First of all, look at the heart position. Is the apex pointing to the left? And when you are saying pointing to the left, there is an imaginary line that we should always acknowledge. We don't physically draw it, but this is the imaginary line which I'm demonstrating here, which is passing through the vertebra and going all the way to the sternum. I'm sorry I didn't draw it well, but probably the line should pass through here. Sorry. Anyway, even these very bad lines, they can demonstrate that the apex is tilted more towards the left of the baby. Rather, it's not on the center, it's not on the right. So we should make sure that that is the correct position that the heart is in. But remember, for you to be able to lateralize the baby, to say which one is the left side of the baby, which one is the right side of the baby, you should have identified the left shoulder to say where is the baby's left shoulder. You cannot just go on the heart and say where the heart is looking is where the left is. No. You lateralize the whole body of the baby. So in other words, you go on the baby, you see how the baby is lying, then you identify where the left shoulder is, where the right shoulder is. Where the left shoulder is where the heart apex should be facing. So you do not determine the heart position by going to the thorax, because if there's the dextrocardia, you are going to label the baby's right side as the left side, because sometimes you have a heart that are actually pointing this way. So it is very important to recognize this. Let me see if I can clear my, so that we can continue. Right, great. So then the heart angle, the apex, the left ventricle should be apex forming. This is the left ventricle, this is the right ventricle. How do we identify that this is the left and this is the right? The right ventricle always has a moderator bend. This is the moderator bend. Let me freeze the image maybe. Right. So, oops. What should I do? Right. Let me. Right. So the moderator band is this piece of tissue we see in the left ventricle, in the right ventricle. So this piece of tissue here makes the right ventricle look like it's not, it cannot be completely filled all the way to the end. So this piece of tissue sits right at the bottom of the right ventricle is called a moderator band. So this is how we identify the right from the left. It is not the position. Don't say the ventricle which is more to the right of the heart is the right ventricle without looking for the moderator band. Because there are certain conditions like correct transposition of the great vessels where the right ventricle will be on the left and you are going to see the moderator band here on the left side. So look for the moderator band. Any ventricle that is the moderator band, know that is the right ventricle. If you see it on the left, then you know you are probably dealing with the corrected transposition of the great vessels. All right. So let's continue the heart. I'll just take it slowly because I think we want everyone to be able to do it easily because it should not be difficult. People who have been scanning for some time now. Then the heart angle has to be between 30 and 70. How do we know? How do we draw the heart angle? If you go to fetal echo settings on the machine, there's something called cardiac angle. So if you follow that cardiac angle position and you happen to draw a line from the sternum like this, it's easy to do on the machine than I'm doing here. It's much easier. Then the other line follows the interventricular septum. It will go straight like this. So which one is the cardiac angle? That's the question. This is the cardiac angle we are talking of. So the cardiac angle should be between 30 to 70 degrees. If it goes below 30, then the heart is tilted towards the right. If it goes above 70, so that means it will be like this. The heart is deviated to the left. So this will be called left axis deviation. This one is right axis deviation. So that's what we mean by the heart angle or the cardiac angle, which you should check on the 4-chamber view. So while the heart is moving or beating, if you eyeball the heart and you are not certain that the angle is correct, then in that case, the measurements have to be done. Let's clear this. Erase all ink. Okay. Then If you eyeball the heart and you're not certain of the angle, then you have to do the measurements. You freeze your 4-chamber, make sure you're in the right plane, because if you are oblique, you may get an abnormal angle because you are not in the right plane. So make sure you're in the right plane. You can see one rib. You can also see the lungs on the side here. Okay, then heart size. The heart should make up 1/3 of the thorax in terms of the surface area covered, almost 1/3. It should never exceed half of the thorax. It should not be more than 50% of the thorax. If we are in doubt, we can measure something called cardiothoracic ratio. How do we do it? Most machines, they do have it under cardiac echocardiography settings. How does one do the cardiac angle, cardiothoracic ratio? The cardiothoracic ratio, we do it by measuring the circumference of the heart. So the application in the machine will allow you to do this. So you're going to measure the circumference of the heart like this. So this is the circumference of, sorry, my English passed there. Right. So this is the cardiac circumference. Then the next thing is to measure the thoracic circumference following the rib position, not the skin of the, we don't follow the skin of the thorax, we follow the ribs, right? Then we measure the thoracic circumference. The cardiothoracic ratio will be a ratio of the cardiac circumference divided by thoracic circumference. That's what we call cardiac thoracic ratio. If the cardiac thoracic ratio is more than 50%, then indeed we have a cardiomegaly. But the interpretation always has to be in context. Sometimes you have a situation of small thoraxes. In cases of pulmonary hypoplasia, those women who come with anhydramnios or oligodramnous early, they're going to have small lungs. So that's not a true cardiomegaly, right? Because the heart looks big because it's appropriately grown and the thorax is small. So the thoracic circumference has to be within normal. There has to be nothing wrong with the bones, because you also see small thoraxes in cases of skeletal dysplasias, the achondroplasias and so forth. So always interpret it in context. For a normally growing baby with a normal thorax circumference and diameters, if the cardiothoracic ratio is greater than 50%, there is cardiomegaly. But the context matters to say, do you have skeletal dysplasia with very small ribs? Do you have a case of pulmonary hypoplasia where the lungs didn't develop? We are obviously going to get an abnormal cardiothoracic ratio, but it doesn't mean there's cardiomegaly there. Right. Then let's clear the colors. Let's continue with the 4-chamber view. Okay. How do I clearing this? Right. Okay, there we go. The next thing is you want to look at the size of the arteries. Which ones are the arteries? The arteries are these two chambers at the top here, where the blood arrives first and is emptied into the ventricles. So these are the arteries here, the two arteries. We say you should make sure that they are symmetrical. But in reality, when you eyeball the heart without bias, you may see that the right ventricle, the right side of the heart looks slightly larger, just slightly larger than the left. It is normal. The reason why it is like this is because the right side is the systemic pump, does most of the work in the uterus. But it should not be grossly, there should not be gross discrepancy between them. They should look almost equal when you are eyeballing the heart. So this is the atria and the two atria, the right atria and the left atria. How do you morphologically distinguish the two atrias? Because in certain cases, you could have a duplication of the arteries, like the issues of isomerism, the heterotaxis. You may have duplication of one atria. So how do you know that this is the morphologically left atria, right atria, and this is the morphologically left atria? If you are in the correct plane, the correct four-chamber view plane, you are always going to see the pulmonary veins going into the left atria. These are the pulmonary veins you see here. You see two of them in any given plane. There are four, remember, that empties into the left atria, but in any plane you can only see a maximum of two. So these left pulmonary veins help us distinguish the right atria from the left atria. The right atria doesn't have any vein that goes into it. At the four-chamber view, it doesn't mean it doesn't have vein. Remember, that is where the inferior and the superior vena cava drains into, right? But in the four-chamber view, you do not see any vein. But sometimes you may see the coronary sinus close to it if it is dilated. Sometimes the coronary sinus is dilated. It's not a harmful condition, but sometimes we may see a dilated coronary sinus close by. But in most cases, you're just going to see this with these plain smooth muscles, and there is no vessel that goes into it. While the left, there are two pulmonary veins that drain into it. So that is it about the arteries. Okay, it's coming later on. I wanted to maybe let me just finish with while I'm on the atria. Then within the atria, we have the okay. Let me follow this order so that I don't disrupt your mind. Then let's go to the ventricles. We should make sure that the ventricles of appropriate size, equal size and thickness, and equal contraction. So as the heart beats, as I was saying, that when you eyeball the heart, they should look almost equal. If the heart looks just slightly marginally big on the right, is not a big issue. More so towards 10. But they should look almost equal. There should not be obvious discrepancy in the size of the two ventricles. Then look at the contraction to see if they are all contracting the same way, the two sides of the heart. That is the right and the left. I've already taken you through how to identify the right and the left. The left ventricle is no moderate bent, and it is the one that angers the apex of the heart. This is the apex. The apex is the very tip or the distal tip of the heart. That's what we call the apex. In a normal heart, the apex should always be formed by the left ventricle. So the left ventricle should always be forming the apex, as you can see there. Always. So that's the left ventricle forming the apex. If the left ventricle is not forming the apex, then there is a gross abnormality of the heart. We'll talk about those gross abnormalities, say what heart defects will cause the heart, will make the heart look like the left ventricle is not forming the apex. So we will go through those ones. Then the motor data bend. Okay, I've already emphasized the issue of the moderator bend. To say the moderator bend is in the ventricle. Please look for the moderator bend. Don't just look on the right side of the heart and say, oh, this is the right ventricle without checking the moderator bend. The AV valves should be patent. Patent means they should allow flow in and out of blood. And they should be of equal size and opening equally and fully. This is why you need a higher frame rate This is why you have to change to the cardiac settings so that you can capture these movements here. Without a higher cardiac setting, higher frame rate, you will fail to capture the movements. Let's see. Let's go through it again and just demonstrate what we are referring to. So if you are to play it slowly, you can see the frame rate here was not the highest you can get. You can get it better than this. You can see how we are struggling to just demonstrate. Yeah, there we are. So these ventricle valves are opened now. You can see. So make sure they are opening fully. Then in this plane, they are closed now. You can see the valves are closed and now they open. So the cardiac settings allow you to see these openings and closings at the right cardiac settings. Then they should look equally in terms of the distance, the diameter, this diameter here, the AV valves, and they should all open. Then they should be normal crux. Crux means just cross, a normal cross. It's a French word for cross. The tricuspid should be lower than the mitral. So when you interrogate the AV valves, let's see, previous. Okay. So as we interrogate the AV valves, right, this is the tricuspid valve. The AV valves of the right side of the heart are called tricuspid valve. Tri means three. That means there are three cusps there that form the valves. So the valve is not a one flap. There are three flaps that make up the valves on the right side of the heart. That is why it's called tricuspid. So the tricuspid valve is set at a lower level. When we are saying lower, we're saying the atria is the upper part of the heart. The ventricles are the lower part of the heart. We are not referring to the image you are seeing, because obviously the image you are seeing, it looks like the apex is the upper part and the atria is the upper part. No, we are saying morphologically, the upper part of the heart is the heart where the atria is. Then the lower part is the part of the heart where the ventricles are. So when you are saying the tricuspid inserts at a lower part, we're in reference to say it's more closer to the ventricles than the mitral valve. The mitral valve is also called a bicuspid valve. The bicuspid means it has got two flaps that make up the valve. So here you can see for yourself that the tricuspid, this is in reference to the septum, to the interventricular septum, where we are saying inserting. So you can see here that it's inserting lower, this one is inserting upper. This is the normal. If we lose the crux, that means we have a defect, most likely an AVSD defect, an atrioventricular septal defect. So the crux should always be checked. You can see it form some form of an X if you want to be gross, right? So if we just draw a line here, let's just demonstrate it. We have to make everyone believe. Let's see. There we are. Then this one. Yeah, you can see an X is coming. So that's an X. We can see a crux. The French make maybe a French crux. But it's a form of cross. We can see here that it is a cross of some sort. So this is why it is called a crux. We don't want you to wonder and say what is a crux, but a crux means a cross. It's a French word for cross. Right. So let's move on. Then the foramen ovale. What is the foramen ovale? The foramen ovale is this gap you see here on the arterial septum. So this is the foramen ovale. Foramen should mean hollow. I think it's a Latin word or something. I'm not sure. But foramen just means there's a wall there, a wall in the heart. But this is a physiological wall. It's not an abnormal wall in the heart. So this wall is not an open wall. It has a flap which closes it. But this flap will open and close, allowing blood to unidirectional flow of blood. So in other words, it's a one-way valve kind of system where it allows blood to only flow in a certain direction and not in the other direction. So for us to say there is a normal heart, this flap should only show that unidirectional flow. The moment, so let's demonstrate the flap. I think the flap should come out nicely here. Let's just see. Let me change my pointer. Right. Then let's it play. So we can see here that there's a small flap here which is denting on the left side of the heart. What does this do? Remember, the right side of the heart is the systemic pump. But the right side of the heart, the weakness of the right side of the heart is that it doesn't communicate with the brain, with the fetal brain. There are no vessels from the right side of the heart that go straight to the fetal brain. The right side of the heart communicates with the rest of the body through the ductus arteriosus. That is the lower part of the body from the head downwards. It is communicated via the ductus arteriosus, which is a very big vessel, which comes from the right side of the heart. So if the right side of the heart is the systemic pump, the question now is, how then does the brain get the oxygenated blood? Because the oxygenated blood is coming via the inferior vena cava and the ductus venosus is coming from the placenta to the right side of the heart. How then does it get to the left? It gets to the left side through this wall, the foramen ovale. That is its role, to allow blood to go to the left, oxygenated blood to go to the left side of the heart so that it can be pumped by the left ventricle to the fetal brain. Otherwise, without the foramen ovale flap, or foramen ovale here, it is impossible for the baby's brain to get oxygenated blood, because there is no communication between the right side of the heart and the fetal brain in terms of blood supply. So that is the role of the foramen ovale. It is a very important gap or opening or a hole in the uterus because it allows the heart to function and to feed the baby's brain with oxygen, right? So the flap should always be on the left side. If you look carefully, there's a flap. Probably this image is not the clearest, but try to look at the heart carefully today. You are going to see that there's a flap that is making this a one-way valve. So in other words, this is a one-way valve system. It doesn't allow blood to flow opposite. In certain conditions, the flap is pushed over. These are very gross fetal defects. So if you see it on the right, then you know we are in trouble. There is something going on in the heart which is a little bit serious. That is, push the pressures and make it deflate and go opposite. Push the valves in an opposite, the valve in an opposite direction. Right. So then the interventricular septum should be intact. This is not the right plane to examine the interventricular septum. Why? Because there's always a drop-down effect that will make you think there's a hole here, right at the end, if you don't look carefully. So you may think there's a wall because of the drop-down effects, because ultrasound doesn't image well this part because of the position. You need to horizontalize the septum and look at the septum, because the ultrasound only shows clearly structures it is in contact at 90 degrees. Like you can see, the valves are coming out nicely because they are 90 degrees to the beam there. That's ultrasound scan physics. Please watch the physics lecture on the website so that you are more informed on physics. You cannot just scan without knowing physics. No physics, how things work. So the pulmonary veins should drain in the left atrium. I've emphasized that. The interventricular septum is examined all the way up to the atria, and you should make sure the foramen valley gap is there and the flap is in the left atrium. Yeah. Then the lungs should be seen to be present, and make sure that the lungs appear normal. This is the left lung and the right lung. The left lung will always appear smaller, and by the way, it is a bilobed as well, the left lung, because of the heart position, which is squashing there, while the right lung is trilobed in terms of size. So the right lung will probably appear bigger than the left, because some of the space of the left lung is taken by the heart. Then there is a vessel you are seeing here. This vessel is the aorta, the descending aorta. You should always see one vessel. If you see more than one vessel here, there is an issue which is going on, and this baby needs to be referred at the fetal defense for fetal echo. So you should not see more than two vessels here, no matter what you see. Great. So 4-chamber view. I think I don't think I should go beyond 4-chamber view today, because the 4-chamber view on its own, it's a hell lot of information, which I think you guys may need to try and get it today. So to just demonstrate to you there, that's the right ventricle, left ventricle, right atria, left atria, the aorta, and these are the lungs. You see there. Yeah, just one clever person to tell us, what are we seeing? Is this a normal 4-chamber view? I'm sorry, it's not looping nicely there, but what is abnormal about the heart? From what we have just said, just check understanding. What is going on? What can you see? Just tell us the things which are not normal from what we are discussing. I think there are more than 5, 6 things which are not normal. So everyone can say something, I think. Look at that chart. You can just type what you think it is or what you think is abnormal from what you have just said. Guys, I need answers. I'm waiting for comments to hear what people think. There is a 4-chamber view there. Let's get some takers. One response has come. I need more before I start reading them out. Let's have more. So the first answer I've got 3-chamber view. Fine. Maybe we can see say loss of 4-chamber view, right? But it's never a 3-chamber view. If you look carefully, it's not a 3-chamber view. It's still a 4-chamber view, but with a large arterial septal defect and also a ventricular component, which make it an AVSD. you can see that there's no crux at all. You are right to say there's a loss of the crux because the heart is now having a common entrance canal here. That common canal is because there is malformation at the level of the crux. You can see the opening. Let me demonstrate the opening here. Look how the heart is opening here. Look, it's a very large chamber. Let me see. Here, I'm just missing it by a whisker. Here, look, this is how the heart is opening. It's just one common opening now because the valves are all tethered around the AV junction. So all the 5 valves are now on the sides instead of being tethered to the IVS because there is nothing. There's a large defect here, atrioventricular septal defect right here. As you can see that there's nothing on that part. So this is a large AVSD. And there is also asymmetry of the ventricles. It's quite clear that the left appears to be bigger than the right here. And we are not seeing the pulmonary veins clearly. If we don't see them, it could be just a duplication of the left atrias, which we normally see in left in cases of left isomerism with duplication of the 2 left atrias there. These babies' hearts beat slower than normal. So they beat probably around between 60 and 100 beats per minute because they are controlled by the AV node instead of the sinoatrial node because they'll be missing a sinoatrial node. You remember what we said about the sinoatrial node and the rate last week. Before we finish, sorry, let me see. Oops. I don't think I have the image I thought I had, but I think I want to stop here with the 4-chamber view. Next week, we may have an interruption. We may ask one of our registrars who is rotating that to present some few cases. Then the other week, or depending on if people come up with cases, I will just go through some examples of abnormal 4-chamber views. Then once we are done with that, depending on what will be happening, we'll go through the 3 vessel views. But next week, we'll be having some case presentations from one of our registrars rotating through the fetal medicine. Thank you. Bye-bye.